Hey everyone, this is the Family Docs Podcast brought to you by the California Academy of Family Physicians, and I'm your host, Dr. Assibey, CAFP's new Physician Director and Associate Program Director at San Joaquin General FMRP. I'm originally from LA and currently practicing full-spectrum family medicine here in the Central Valley. I'm super excited to be back with you, bringing new episodes of our Family Docs podcast with some incredible new guests, topics, and content for you. In this episode, we'll be talking about data exchange, the data exchange framework, and the data sharing agreement. So, you're probably wondering, what is the data exchange framework and data sharing agreement? Great question, because I'm glad you asked. The Cal-HHS Data Exchange Framework, or as we'll call it, DXF, is California's first ever statewide data sharing agreement, aimed at improving the secure and appropriate exchange of health and social services. Now, to understand what signing onto the DSA will mean for physicians and the patients who serve, CAFP has been partnering with BluePath Health and Transform Health to share informational materials around the DXF. Today, we'll hear from our fellow family physician, Dr. Sumana Reddy from Acacia Medical Group, and Andrea Frey, Senior Counsel at Hooper, Lundy, and Bookman. Dr. Reddy brings her wealth of experience as a family physician, and Andrea Frey, with her expertise in digital health and data privacy, is here to shed light on the intricate landscape of the data exchange framework. Stay with us as we navigate through the legislative background, implementation timelines, and address concerns pertinent to family physicians in California. For more resources and information, check out our show notes. I'm Dr. Assibey, and this is the Family Docs Podcast. Now let's dive into the world of data exchange.
Hello, I'm Dr. Sumana Reddy. I'm a family physician with Acacia Family Medical Group in Salinas. The CFP is partnering with Connecting for Better Health to provide educational resources for CAFP members on data exchange and to gather feedback or concerns family physicians may have with data exchange and the data exchange agreement. As part of this work, we are pleased to have Andrea Frey, Senior Counsel with the law firm Hooper, Lundy, and Bookman, with us today to talk about data exchange, the data sharing agreement, and what this means for us as California Family Docs. We will have information, links, and other resources available in the episode show notes. But Andrea, tell us a little bit more about you and how you fit in within the world of data exchange.
Yeah, well, great to be here. Thank you to CAFP for hosting us today and for putting on this podcast. And great to meet you as well, Dr. Reddy. So as you mentioned, I'm senior counsel at the law firm of Hooper, Lundy, and Bookman. We exclusively represent healthcare providers across the state of California as well as nationally. My practice is very much in the data privacy, data sharing, interoperability space. And so how I've kind of come into this is over the past year, I've been working with an organization with whom CAFP partners called Connecting for Better Health, really to kind of put on various educational kind of office hours and sessions over the course of the year about the statewide data exchange framework, what the upcoming requirements are and obligations for providers across the state. And so very much, both in that role as well as in my own role advising clients directly, I'm trying to figure out what the obligations are going to be for these clients as they sign on to the data exchange framework. And in terms of actually sharing in real time what that looks like and operationalizing it as far as the exchange of health information through the framework. So that's how I came to kind of be in this world of data exchange.
That's wonderful. You're bringing so much depth to the conversation, it seems. Can you tell us more, Andrea, about the data exchange framework?
Yeah, certainly. So I think just to set the stage for our conversation today, the data exchange framework is the first ever kind of statewide data sharing agreement that really focuses on mandating kind of an accelerated exchange of health information among healthcare providers, health plans, government agencies, and social services programs starting early next year. And by early next year, January 31st, 2024, so right around the corner. And it's really intended to kind of break down the existing silos with regard to health information that have made it pretty difficult, both for Californians to access effective kind of whole person care, but also for government agencies and other providers to really get information they need. The impetus for the data exchange framework really came about kind of in the height of the COVID-19 pandemic in 2020. As state officials, we're pretty desperately trying to get information, collect information about COVID-19 and health outcomes regarding patients from health and social services organizations across the state, and coming up against pretty serious issues because of kind of these varied information silos and voluntary patchwork of different approaches to data sharing that we have and that existed across these organizations. For example, like one health system may use this EMR, another provider, a smaller provider, family physician, for example, may keep everything in paper records. So it definitely created a lot of challenges and really pulling together kind of the necessary data to give us a statewide picture of how the pandemic was affecting Californians. And so, I think kind of the intent behind the underlying legislation that really gave birth to the data exchange framework, and it's Assembly Bill 133 or AB 133 as I'll call it, that kind of put California on the map toward building this kind of data exchange framework and create a statewide mandate that allows for the collection and exchange of information on a more kind of actionable and timely basis within and across these various health and social services organizations, so that we really could kind of be in a place to have a better understanding, of health information outcomes across the state and really manage, more effectively the health needs and conditions of individuals and communities and kind of drive this notion of whole person care forward.
Thank you, Andrea. We've certainly struggled over the last 15 years of EHR development, and I don't think any of us anticipated that we would not have reached this goal by now. So it's certainly timely and beyond timely to get this going. I know that I participated in a health information exchange some years ago, but it just did not, come to fruition in the way that we had anticipated at the time. Can you tell us a little bit more here about policies and procedures? Sorry, backtrack on that. You were going to comment there.
I was just going to say, you're completely spot on. The evolution of health information exchange, both across the country and then the state of California, has really been a pretty slow and disjointed rollout, at the federal and state level, and certainly has created a lot of challenges for, our clients and then just the health, healthcare industry as a whole. I was just going to say, you're spot on, Dr. Reddy, in that regard.
Thank you, Andrea. And now I'm wondering about the components of the data sharing agreement, how that would be set up, and what sorts of policies and procedures will govern this data sharing agreement.
Yeah, great question. So definitely to kind of break down the data exchange framework into the sort of core components, I think the centerpiece really is the data sharing agreement, which is, I'm looking at it right now, and it's a 9-page document, basically a legal contract that is signed by participants on the exchange, and kind of creates this shared commitment both among mandated participants and happy to get into this, but basically hospitals, physician organizations and medical groups, skilled nursing facilities, health plans, and clinical labs, as well as voluntary signatories, and that includes county agencies and social services agencies, to basically agree and be bound to kind of this secured and appropriate sharing and exchange of health information. And so, the document under AB 133, the implementing legislation that gave rise to the data exchange framework, the DSA, or data sharing agreement, has to be executed by most participants as of January 31st, 2023. So that's, last January. And as I noted, it kind of really lays out the parameters for how data exchange, should happen among these participants. But I will say, predominantly it leaves kind of the how, when, where, why, kind of the technical details in the accompanying set of policies and procedures. That's really where we find the technical specifications and standards that have been promulgated by the agency that's been tasked by the state to develop these, and that's the CDII, or Center for Data Insights and Innovation. And so the PNPs, they've been under development since kind of early 2022 and still continue to this day to be in development. We've seen a number of PNPs that have been finalized by CDII, and that's usually through a pretty drawn out stakeholder process involving public comment and discussions in various committee and subcommittee meetings. And then there are also a number of PNPs that are still in the works by CDII, and as well as those that are in the process of being amended. And these range from topics including, for example, who is required to sign, what happens in the event that the participant experiences a breach of health and social services information? What are the type of data elements that participants have to exchange with other participants? What kind of privacy and security safeguards, for example, that participants have to have in place in order to ensure the integrity and confidentiality of the information? And then the PNPs also get into, for example, kind of the more technical requirements for exchange, how individual patients themselves can access health and social services information from participants. And then a pretty similar to the federal rule regarding information blocking, there's a PNP that also has a description on practices that constitute information blocking and are prohibited by participants. So there are a couple, and I'm happy to go, into more detail on any of these, but, they're all of the PNPs, including both the draft and the finalized ones, are available on CDII's website. So, to the extent you have determined you're either voluntary or a mandated participant, definitely worth going to CDII's website to review each of these PNPs in detail.
Thank you, Andrea. That's a lot for us to digest at this time. You went into some detail about the practices that needed to sign by 2023, and I just want to get that clarification on who needs to have signed by next year and who doesn't need to participate until 2026.
Yeah, great question. I think there's a bit of a difference between who needs to sign and then, which is essentially any mandated participant under the law, is CDII takes the position that these participants need to have signed already by January 31st, 2024, regardless of the date in which they need to actually implement the data exchange framework, which is there are two separate buckets. So you're spot on, Dr. Reddy. There's by January 31st, 2024, there's this sort of first category of mandated participants, including general acute care hospitals, physician organizations and medical groups with 25 or more physicians, clinical laboratories, skilled nursing facilities that maintain electronic information, healthcare service plans, and certain like acute psych hospitals with 100 or more beds. These are the types of participants that by law are both required to have signed the DSA by January 31st of this year, but then also begin implementing the exchange of information by January 31st, 2024. At the same time, there's sort of this separate bucket of smaller practices, rural hospitals. So practices, what I mean by smaller practices is a medical group or a practice with less than 25 physicians. In addition to, a nonprofit clinic with fewer than 10 providers, long-term acute care hospitals, critical access and rural hospitals with less than 100 beds. These kind of types of providers, I think the state is really acknowledging that they need additional investment and kind of time to be able to ramp up the technological capabilities and capacity to be able to engage in health information exchange processes. And so for that reason, the law and the implementing DSA and PNPs gives these providers until January 2026 to actually begin exchanging data.
If practices have already signed with an HIE or a national network, should they still sign the data sharing agreement?
Yeah, great question. So essentially, and I should probably back up too and say, the data exchange framework is really intended to be technology agnostic. And is not sort of a single repository that the state is creating, in which all providers, health plans, and other participants are sharing information. Instead, it's kind of supposed to be sort of rules of the road for how organizations, on a collective basis are going to be providing access to an exchange of information. And so, certainly the data exchange framework allows participants kind of some flexibility in terms of how they ultimately provide access to or exchange information with other participants. And that may be through an exchange network, a health information exchange, an HIO, or some other sort of form of technology. And ultimately, if it adheres to the DSA and the policies and procedures that have been promulgated by CDII, then a participant or a small practice, can ultimately comply with the data sharing agreement, but you do still have a separate obligation to actually sign the DSA. So yes, even if your practice is currently exchanging data over one of these networks, you do still need to sign the DSA. And I do think, there's going to be, the state right now is currently in a process of approving organizations to qualify as a qualified health information organization in which participants, if they join one of these QHIOs, the state has said, they meet all of the requirements under the data exchange framework and comply with the PNPs. But that doesn't, you are not mandated to join one of these QHIOs, but if you don't and you're using a separate national network or something else, you do still have an obligation to kind of do your due diligence and make sure that that system or exchange that you are using actually can meet, satisfy the requirements of the DSA and PNPs, or allow you to satisfy the DSA and PNPs rather.
Thank you, Andrea. And my understanding is that that is the difference that determines the funding that is available to you, whether you join a QHIO and then I think the maximum is $35,000, or do your independent due diligence and the funding you qualify for maybe up to $50,000, which is really good to hear.
Yeah, I was going to say not an insignificant amount, so certainly something that can help folks make sure that they, I think it's worth leveraging that funding opportunity from the state if possible to, be able to engage in the data exchange framework.
Absolutely. And now, Andrea, I understand that you are have special expertise in reproductive health privacy. This is something that's of great interest to me, and I'd love to hear you share with us some of your thoughts on those types of privacy issues.
Yeah, definitely. Well, and I should back up and say, the firm that I work for, Hooper, Lundy, and Bookman, we have a reproductive health practice group, of which I'm the firm's co-chair on that. And so this is certainly an area, and myself as a, data privacy attorney, I'm very much closely paying attention to, and very much, I think there are a ton of concerns by healthcare providers, and patients equally, around kind of what the Supreme Court's decision in last year's Dobbs case, which overturned the constitutional right to an abortion under Roe v. Wade, what the implications are for that decision around how patient medical records and information can be, used to penalize both providers themselves as well as the patients, for seeking, obtaining, providing, or facilitating essential reproductive health care services. And this is, certainly going to be true as state prosecutors and law enforcement agencies really turn to, medical records and health information as kind of in the search for evidence of both civil and criminal violations to really enforce, a state's restrictive abortion laws. So I think this is a great question to ask, and certainly something that both the federal government and the California legislature and Governor Newsom are very much, concerned about as well. And you see that, for example, here in California, Governor Newsom just signed a new law, AB 352, which requires basically electronic health record, EMR systems, any sort of business that electronically stores or maintains medical information. That includes sensitive services information on behalf of a provider of healthcare or a pharmaceutical company or a health plan, for example, on or before July 1st of next year, to really create kind of certain security features, be able to limit user access privileges, and actually segregate medical information that relates to abortion and abortion-related services, contraception, and gender-affirming care. The law also goes into detail in terms of updating the data exchange framework so that it actually excludes from the implementing statute, Health and Safety Code Section 13290, basically any information, any health information that's related to abortion and abortion-related services from automatically being shared over the data exchange framework. And this is, I'd say, just kind of at the state level. We also have, for example, the Office for Civil Rights through the U.S. Department of Health and Human Services, which oversees and enforces the federal law, HIPAA. Just recently, back in, I believe it was April, promulgated a proposed rule that would update the HIPAA privacy rule standards around basically where a covered entity can share protected health information, in the investigation or a lawsuit or prosecution of patients, a provider, and others who are involved in lawful reproductive health care, such as abortion. So we do have, a lot of kind of moving pieces in this area to really try and ensure that, following the Dobbs decision, there are bolstered privacy protections for reproductive health care. But it is, still of concern in terms of do systems have the technological capability to be able to meaningfully segregate this data? How much more work does that impose on providers, in terms of actually tagging it as they provide this care? So I think we still have, some questions to kind of go through and figure out how we actually, operationalize this, particularly with the data exchange framework. But, I think there are significant efforts being made to at least ensure that this information is protected.
Thank you so much, Andrea. In fact, you have just answered a lot of questions that I have been asking people, and I know this is just nascent, and so I don't know that everyone working in this area has thought it through in the way that you have. In fact, it is that specific concern about EHRs have not yet done the work to adequately segregate as desired by the clinicians sensitive information. And if it's going to be driven by the Dobbs decision and reproductive health, so be it. But the CAFP has been at the forefront in obtaining, for example, for conducting ACE screenings. And so when we talk about very sensitive, adverse childhood experiences and trauma, this is not something that I want going to every specialist or every clinician involved in that person's care. And so behavioral health and the way in which counseling records have been much better segregated. We have gone from family doctors not being reimbursed for caring for depression. We used to have to put codes for fatigue and insomnia when treating depression, in the early part of my career, to now we are being expected to treat depression and anxiety. And there are times when the narrative may just be something I don't want to share. So we are going to have to figure this out in order to get the participation of, everyone who cares about privacy in the way that you and I do, And so thank you so much for that, excellent summary of where things are now. And I'm really going to make a pitch for you and everyone else involved, pushing the EHR companies to help with that, support for the segregation of data appropriately.
Yeah, I think that's spot on. And there's pushes too to get the federal government, for example, ONC, to really kind of create better standards around data segregation. I think we'll see more developments in this space going forward. But I think you're right. This goes way beyond reproductive health information. For example, substance use disorder records, HIV/AIDS test results, any sort of STD test results. There's very much sensitive information that I'm sure you all as family physicians frequently are taking in and including potentially in the patient record. And so I think it also gives rise to, it's especially as the data exchange framework, is implemented, to have conversations too with patients and be transparent about the ways in which, and I think this takes place on a community level as well as a provider to patient level of, let's have these conversations and make sure patients are meaningfully engaged in as part of this process too, and aware of how their information is shared, and whether that is, for example, opting in or opting out of having their information shared on the exchange, signing an authorization form, whatever it may be. I do think having patients meaningfully involved in this process, it will be helpful as well.
Yes, thank you. Now, looking backward, many clinicians have paper records from prior years. Is there a look-back period included in the data exchange framework?
So there's not actually any specific look-back period, and if you look, on a general basis, health and social services information, which is kind of how both the data sharing agreement and the implementing PNPs describe, what participants are mandated to share and exchange with other participants. That broadly refers to kind of any related information that individually identifies a patient and necessarily, could be contained within a paper record. But if you go to the actual specific policy and procedure that focuses on data elements to be exchanged, that gives a little bit more specificity in terms of what CDII is envisioning participants actually share with other participants and provide access to. And it actually references back to federal obligations around electronic health information that was specified by the information blocking final rule that came out in April of 2020. And so electronic health information at this point really is just kind of the whatever designated records that you have regarding the patient that's maintained electronically. And so, to the extent you have records that are still on paper, at least as of this time, there's not any sort of obligation that you have to go through and spend the time, uploading it to your EHR system or whatever it may be. But I do think in order to really meaningfully comply and be engaged in this process, it is helpful, for providers to start thinking about that transition to an electronic system and having records on an electronic basis rather than maintained, in paper form. But no, I guess that was kind of a long-winded way of answering your question. There isn't a look-back period in the data exchange framework, at least currently. That could be something, we see developed in a future P&P, though. So it's a great question and certainly something to be kind of paying attention to as we move forward in this process.
Good to know. Thank you, Andrea. Where should our clinicians, our doctors go to learn more and stay updated on the data exchange framework?
Yeah, so, I think we mentioned this at the top of the call. Connecting for Better Health is part of, this multi-association initiative around the data exchange framework. And they have on their website this information hub that has both resources, various stories, information about grants, for example, that are available. And they also put on these coalition meetings that, involve various experts and providers that meet twice a month. And then they also have office hours in which I will sometimes present, regarding the data exchange framework. So certainly, I'd recommend checking out the Multi-Association Initiatives Hub through Connecting for Better Health. And then, frankly, honestly, the CDII's website is also a really great resource and provides all the information that you need about how to participate and provide public comment at any sort of implementation advisory committee meeting, particularly as the various P&Ps that are still under development are discussed. It's really helpful to go to those meetings and both get a better understanding from the regulators themselves what they're envisioning, but then also have your voice heard if you have questions or comments as well.
Well, thank you very much, Andrea. I know that we've really appreciated your valuable insight, expertise, and time. The CAFP has created this resource that if you're listening to, you have a start on knowing where to go to learn more about this. You will find more information on the data exchange framework in the show notes or visiting connectingforbetterhealth.com. I'm Dr. Sumana Reddy. Thank you for listening.
Thanks to Dr. Reddy and Andrea Frey for that incredible conversation. And special thanks to the Data Exchange Framework Multi-Association Education Initiative partners, BluePath Health and CDII. You can find out more information on CAP's work around this, including an introductory webinar, short videos around implementation funding, and links to more information at familydocs.org/DXF. Hey Family Docs, I want to let you guys know about a special annual event for CAFP, AMAM, or All Member Advocacy Meeting. Now, this is a 2-day event in Sacramento that gives you a tremendous opportunity to learn how to be the voice for your patients, collaborate with local leaders, state legislators, and policy stakeholders to improve the health of all Californians. When does this happen? April 13th through 14th, with a special lobby day on Monday, April 15th, in your white coats at the Capitol. Great moment to meet face-to-face with your local representatives. Join us, your fellow family docs, and raise your voice for your patients. I know I'll be there, and I look forward to seeing you there too. Registration is now open, so go to familydocs.org/AMAM to sign up. The Family Docs podcast was developed, produced, and recorded by the California Academy of Family Physicians. The views and opinions expressed in this program are those of the speakers and do not necessarily reflect the views or positions of any entities they represent or the California Academy of Family Physicians. Until next time, this is your favorite family physician, Dr. Assibey with CAFP.